Okay, so good evening, everyone, and welcome to the third episode in our Paediatric series. Tonight's webinar will be all about vomiting in babies. It is my absolute pleasure to introduce Dr. Nisha Aggarwal, who is a clinical teaching fellow at Stoke Mandeville Hospital. She spends half her time teaching undergraduate medical students and the other half working clinically in both pediatrics and neonatology. She did her foundation years in the West Midlands, and tonight she will be joining us for a webinar. Before I hand over to her, I just want to quickly mention our sponsor, which is CPD Me. So through Mind the Bleep, we've got you a 50% discount. So for just £8 for a year, you get the full access to hundreds and hundreds of different webinars that are all CPD accredited. So for you F1s, F2s that need non-core learning for your portfolios, there's an entire variety of things you can go out and get, and you get certificates, and it's all there ready for you to kind of view at your leisure. So now I will hand over to Dr. Aggarwal.
Thank you so much, James. So hi, everybody. As James said, my name's Nisha, and I am really excited to talk to you today about vomiting in babies. So obviously I can't see any of you, and I don't know what paediatric experience you've had. If you have done paediatrics before, I'm sure you would have seen plenty of vomiting babies. If you haven't, it can be something which is a bit scary and a bit unknown, and I think it's quite a common symptom, and it can be difficult to think about all the things that can cause it. So I'm hoping to just use a few case-based examples today from my experience and go through a few common causes. If you've got any questions, then feel free to pop them in the chat, and then James, if you could just let me know, that would be great. And hopefully I'm hoping to just ask a few questions through this as well. So it would be great if you guys could just answer if you feel comfortable. That would be great.
Yeah, absolutely. I'll be monitoring the chat throughout and passing on any comments or questions.
Perfect. So the first thing that I really wanted to cover was what is vomiting. I think it's really easy to just think of vomiting as what we know in adult world, but vomiting in babies can be, or vomiting in babies, as the parents will tell you, can be a lot of different things. So in theory, it's the expulsion of gastric contents due to increased intra-abdominal pressure. But I would say that probably about 50% of the time when parents actually tell me that the baby's vomiting is actually vomiting. A lot of babies just posset, which is just small amounts of milk or stomach contents being expelled, but it's often not forceful. It's more just like a dribble. And as you can see from that picture, that looks a bit like phlegmy. So it may even be that babies who are quite snotty can bring up quite a lot of phlegm just that they've swallowed from their stomach. So often it's not always actually vomiting. Quantities can be really hard to work out. So we will cover this in the sense of what questions you want to ask parents in terms of the vomiting history, but quantities are really difficult. So if parents say they're vomiting the whole feed, it's really difficult to work out if they're actually vomiting 60 mils of milk. It can look quite a lot on a little muslin cloth, and when it spreads out onto a blanket, it can look like quite a lot. So that's definitely something to just be aware of. So in the history, bearing in mind that we're concentrating on babies in this webinar, can any of you suggest what you might want to know from the history? Say the parent, say you've got a 2-month-old who's come in with vomiting.
Okay, I'll just give it a minute or so for people to reply because there is a slight delay.
That's
but when I did some of my training in GP, the things to always ask, I was told, are they eating, are they sleeping, and what's in their nappies? And actually, we're getting some good questions coming in now. So Olivia is saying feeding habits, fever, prior infections. We're also getting the colour of the vomits. 2 different people have just suggested that. How long it's going on for? Is it getting worse?
Perfect. They're all really, really good suggestions. So absolutely. So let's start with what you want to know about the vomit. You want to know when it started. You want to know how much, see if you can gauge how much it is. You want to know the nature of the vomit. So you want to know the colour. You want to know, is it stomach content? Is it blood? Is it bile? You want to know the force that the vomit's coming up as, and that may be able to help you decipher if it is actually vomit. So is it just a dribbling? Is it when they're lying down? Is it when you sit them up just after the feed and they've just burped? Is it projectile vomit that goes straight across the room if you're a metre away? You want to know if it's getting any worse, absolutely. And feeding habits is crucial. So with babies, you want them to be having 150 ml per kilo per day of feed. So with a baby, based on their weight, you want to calculate that, and that's how much they should be having. And parents will often talk about ounces and mils. So 1 ounce of formula is approximately about 30 ml of milk. So that's just an easy way to interpret it. If some parents say that 3 ounces every 3 hours, it can just be a bit confusing, but it's about 1 ounce is about 30 ml. So the age of the child, I know obviously this webinar is about babies, but knowing the age of the child makes a massive difference as to what your list of differentials are going to be. When did it start? We've mentioned. How much? So it's good to gauge an idea, but I definitely take it with a pinch of salt and ask further questions if you're really not sure. How often? So is this with every feed? Is this not related to feeds at all? Is it, every 10 minutes? Is it just once a day? Really good to get an idea. And that will give you an idea of if you think this child is dehydrated as well, which is a really important question, which we'll come on to. Is there any triggers? So is it when they're fed? Is it when they lie down? Is it, it could be lots of things. Is it when they see a bright light or something like that, thinking intracranial cause? Relieving factors. So does it help if mum gives a little bit less feed? Does it help if she gives some Calpol because it might be fever related? What's the colour? That includes bile or blood or coffee ground. Stool, you want to know if they're in their bowels, what colour, if there's any colour change in the bowels. And just remember other bits, so birth history, medications, these are really important for children. Don't forget if they're old enough to have had any vaccinations, don't forget to ask about that. Ask about home life, so you want to know who's at home, has anybody else had vomiting? That might give you an idea as to the cause as well. So the next bit that you do will be examination. So I've got this picture of this baby here because it was quite a nice way to show examining the anterior fontanelle. So the way that I always examine my babies, and you don't necessarily do this for older children, is just go in head to toe. It's the easiest way to make sure that you've not missed anything, and it's the easiest way to just systemically go through and look at the baby. So obviously you'll start by looking at them, and you'll get a lot from just looking at them. You'll be able to see if they're active, you'll be able to see if they're alert, even if they're sleeping, they should be responding appropriately to you. So if you hold their hand, they should still grip, and if you just start to move their arms, they should respond and wiggle a little bit. So you'll be able to see if they're warm, pink and well perfused, things like that. I always start by feeling the anterior fontanelle. So the things that you want to look out for when you're feeling the anterior fontanelle is if it's soft and if it's normotensive. So if it's bulging, you may be thinking about something which is increasing the intracranial pressure. So it's always worth feeling the anterior fontanelle. In babies with vomiting as well, it's worth measuring your occipitofrontal circumference. So you want to do their head circumference. Hopefully, if parents are prepared, they will have the red book with them, and that will have their other head circumferences. And it's worth seeing what centiles are growing along. I saw a baby recently who didn't have any other signs other than the fact that their head circumference had jumped 2 centiles. They weren't vomiting, but they had massive hydrocephalus. So it's really worth remembering to measure the head circumference because it can tell you quite a lot. Hydration status. So a lot of you, I think, may have more adult experience in peds. So just think about what you look for in adults. So it's similar in the sense you want to look for sunken eyes, dry mucous membranes. So still look for things like that in children and in babies. Fixing and following is just an example that I've put of sort of developmental progress. So fixing and following at the 6-week check, they should be fixing and following. So just check that their vision looks okay. Ask mum if she feel, or mum or dad, if they feel like they're watching them and following things around the room. It's a really good indication of vision. Work of breathing, it's worth just having a look at, because if they're vomiting, you just want to make sure that they've not aspirated, or if they're vomiting because they've got a chest infection or a viral-induced wheeze. And then you want to examine their tummy. So you want to firstly look at the tummy, see if you can see anything, and then you want to examine the tummy as well. And then you can have a look everywhere else if they've got any rashes, feel their femorals, things like that.
There was a question from Aparna. She asks, up to what age can you feel the anterior fontanelle?
So it's normally open until about 9 months. It will get smaller and smaller, but up until 9 months, you should be able to feel it.
Perfect, thank you.
So can anybody suggest we've gone over sort of what you'd ask, but what red flags are there in the history or the examination that may turn the warning lights on in your brain of what might be causing the vomiting?
Okay, let's see if anyone has any suggestions. So abdominal mass on palpation.
Okay, yeah. I think that would be definitely something that flags up in my brain, yeah.
Yep, stiff neck is another suggestion.
Good.
I guess thinking kind of meningitis.
Yeah, good.
Someone else has suggested intussusception.
Okay. So we'll go on to that, but yes, that's definitely something which is a serious cause of vomiting, but just more thinking about red flags in the history and examination, because you wouldn't, it's intussusception something you'd come to.
And someone else has suggested foul smelling urine.
Yes, good.
I'm racking my own brains now as well. Thought someone else come with blood in vomit, fever, good. Change in urine output, change in bowel habits. I guess any sort of focal neurology from my own head.
Yeah, absolutely. So they're really good. And I think a lot of the ones that people were coming up with definitely related to neurological causes. And things like fever, I wouldn't necessarily say on its own it's a red flag. Think about things like if it's frequent and forceful vomiting. So I'm not going to say what each of these red flags may indicate, but we'll go through all of them, hopefully, most of them. Frequent and forceful vomiting, bile-stained vomit, hematemesis, blood in the stool, abdominal distension or tenderness, so talking about sort of peritonitic tenderness, chronic diarrhea, and any altered responsiveness or bulging fontanelle. So I've sort of put a few of the causes into different categories. So the main one the main two, I would say, are gastrointestinal causes and central causes. So your gastrointestinal causes can range from reflux to bowel obstruction. It can have a really big range of having a very well baby to a very, very sick baby. You can also have things like pyloric stenosis or infective inflammatory causes such as a UTI or gastroenteritis. And I think, as some people mentioned, foul smelling urine, which is a definite cause. A UTI is a definite cause of vomiting in babies. Allergies and intolerance. So think about babies who are on milk, and also when they start to wean as well. It's important to think about that at about 6 months. Your central causes, so I've mentioned hydrocephalus, meningitis. Always think about poisoning as well. This can be accidental or sort of a non-accidental injury as well. So just think about that. And metabolic. So there are children with complex metabolic disorders. They are screened for 6 of them at the newborn heel prick test. But obviously there's thousands of metabolic disorders. So any child who comes in with vomiting and they are really unwell, possibly with low blood sugars, it may be worth thinking about metabolic causes, but that's something which you will exclude far down the line. I wouldn't say that as your number one cause, but it's just something to consider. So I want to think about a case study now. So let's take this 4-week-old baby who has milky vomits after every feed. Mum stating that, sorry, I don't know if you can see that because of my face is there. Mum states it's projectile. Half of the feed volume's coming up. They're hungry after the vomit. They've tried Gaviscon sachets for 1 day, which she got from the GP. The baby's had normal wet nappies, normal dirty nappies, is putting on weight really nicely, and has had a normal blood gas. So this is based on a baby that I saw in my foundation year 2 year. So we'll work through this. So hopefully reading that, you may have a bit of an idea about what we're thinking about, or at least what differentials we've got. So, So the differentials that I thought of, just for timing, I'll just whiz through them. But gourd, I thought it could be gourd. I thought it could be cow's milk protein allergy. And I also had in the back of my head that it could be pyloric stenosis, particularly as Mum called it projectile. And this is why we did the gas. So the gas was normal. So just to talk a bit about gourd, that baby's so cute, even though it's got stuff dribbling out of its mouth, it's so cute. So gastroesophageal reflux is quite common in children. So the statistics think that about 50% of 0 to 3 month old infants have an element of reflux, and it normally happens around 3 to 4 months of age, but it resolves by 1 year. So a lot of parents will come in and say after a feed, I lie them flat, and they cry, they arching their back. I was on the paediatric decision unit today, and I saw 2 babies with possible reflux. So it's really common, and they all just said they're just so uncomfortable lying flat. And then when I pick them up, they're so much better. Sometimes they might feel like they don't want to have any more feed because it's getting really uncomfortable. And this is when you might notice the posseting as opposed to actual vomiting. So it's literally the milk refluxing up. So that might be a key bit in the history. It's a very clinical diagnosis, reflux, and you wouldn't necessarily do a lot of investigations. In adult land, there is things like esophageal pH monitoring, but even in my time in adults, I don't think I saw anybody with reflux who had that. It was very much a bit of a textbook thing. There is sort of a similar thing that you can do for children and babies, but it's really only if you feel like they're having a lot of consequences from that. So if they've had aspiration pneumonia, if they're having apneas, if you feel like their esophagus is getting very inflamed, or they're having any dental erosion, and if they're having any bile stain vomit or dysphagia, then you can think about an upper GI contrast study but this will mean that you're referring to a tertiary centre because you're worried about something quite sinister. So I would say for the most part, reflux is a very clinical diagnosis. The management of reflux is a lot more conservative than I think is actually practiced. Sorry, let me just move this. So parents will get very, very worried about reflux. They may also think it's colic, which it could be, but often parents will come to you and say, I think they're a bit refluxy. And I think it's really important to reassure parents. It can be really distressing for them if their baby is crying and they're not sleeping and this baby won't settle. And I think it's really important to acknowledge that. For breastfed babies, breastfeeding support team can be an absolute godsend. Breastfeeding is, we as healthcare professionals, we want to encourage breastfeeding. And if there's anything, if babies are refluxy, it can really discourage mums from breastfeeding, but having the breastfeeding support team can help them to continue with it. For formula-fed babies, you can try smaller and more frequent feeds. So as I mentioned, for example, if we had a baby who was on 150, if their 150 ml per kilo per day was, say, 90 ml every 3 hours, you may say, okay, why don't we try 45 ml every 1.5 hours or 60 ml every 2 hours, and it will reduce the volume in baby's stomach and it will reduce the chance of reflux. And that's a really good conservative option. And telling mums to keep baby upright for 30 minutes post-feed will just reduce that distress and irritation. If they're formula fed, you can also get feed thickener, which can be added, which is a good option. It's a good non-drug option. If that doesn't work, then you can use Gaviscon. So infant Gaviscon is good, but then if you are doing that, you would want to stop the thickened formula and go for the Gaviscon. Gaviscon is constipating, so it's not something that can just be used willy-nilly without any consequences. It is very constipating. So you do have to warn parents about that, because it may be that their baby then gets irritated because they're straining and they can't poo. You can also do the Gaviscon for breastfed babies, but they just need to give it with a bit of water before the feed. The use of things like omeprazole and ranitidine are not used very often. I'd say I've seen omeprazole used quite a lot compared to how it's recommended by NICE to be used. So normally they would say NICE has a 4-week trial of omeprazole or ranitidine if there's unexplained feeding difficulties. So sort of not sure why it's gored, but they're really struggling with the feeding, faltering growth or distressed behaviour. If you would stop the Gaviscon then if you're going on to omeprazole, but that can have its own side effects as well. So I think the key thing about reflux is reducing medical intervention and doing a lot of feeding support with parents. The other thing that was running through my mind when I saw this patient, just to go back to that case, remember mum had only tried Gaviscon sachets for 1 day, so that I would say that's absolutely not enough time to have ruled out reflux as a cause for this vomiting. Cow's milk protein allergy was the other thing that was running through my mind and runs through my mind when I see babies with vomiting. So it happens in about 2 to 3% of babies who are formula fed, and it only happens in about 0.5% of babies who are exclusively breastfed, and it's normally before they're 1 year of age. There are 2 ways that cow's milk protein allergy can present or can happen in the body. So it can be IgE related or non-IgE mediated reactions. And the main difference between this is the symptoms and the time. So IgE, think of your classic allergy. So you're thinking urticarial rash, you're thinking itching, you're thinking acute vomiting, loose stools, swollen lips. Think about going along your anaphylaxis symptoms type pathway. Your non-IgE is often more subtle, and that can present with eczema, so really dry skin, blood or mucus in the stool, food aversion, faltering growth, generally quite more insidious onset symptoms that may not be picked up as easily because they're not as obviously a allergic reaction. There may be a family history as well. So in the history, alongside everything else that we asked before, we want to think about, we want to ask about these symptoms specifically. So if they've had a family history, you want to maybe ask a little bit more about the swelling of the lips, the itching, the mucus in the stool, and think about the timing in relation to the milk exposure to get an idea if you're thinking IgE or non-IgE. The reproducibility of symptoms is really important because it may be that parents have already tried a different milk, or they've just started something new, particularly if they've weaned. Is this because they've introduced a new food? When do the symptoms start? You want to really link it to the cause, and if there's any other atopic conditions in the baby or their family. This picture here is skin prick testing, and that is generally what is used to diagnose allergies in children. So it's where you put a small bit of the allergen on the skin and then prick the skin and measure the urticarial reaction that happens. One important thing that is good to know is the fact that the size of the urticarial reaction that you get does not predict the severity of the allergic reaction that the patient will have. It is just more likely that the patient is allergic to that allergen. So you're unable to predict severity from the size of those. It's just if it's bigger, then they're more likely to be allergic to it. You can do serum specific IgE testing, so that's a blood sample, but the results don't come back from that for weeks, and it's generally a bit less available, and so we prefer skin prick testing generally. So management for breastfed babies, you would ask mum to exclude all cow's milk for 2 to 4 weeks. That's generally the advice. Make sure that you specify, because it's a cow's milk protein allergy, make sure you specify cow's milk, not just lactose, because a lot of parents think they're synonymous, but they're not. And if they're formula fed, you can recommend hydrolyzed formulas, or there's also amino acids formulas, which apparently don't taste as nice, but they're the options which don't have cow's milk protein in them. If babies are still struggling with those, then you can go on to get the dietitians involved. And you would want to follow them up in allergy clinic if they have faltering growth, severe reactions, or severe atopic eczema. NICE has a massive list. I didn't include them all here, but if you've got any concerns about their development and want to follow them up, then you can ask the consultants to follow them up in the clinic. The key thing about this is exclusion and re-challenge. So we want mums or parents to exclude the cow's milk protein for 2 to 4 weeks and then re-challenge. And that's the only way that we'll know if this is actually the cause. It can be really difficult if the baby is on a dairy-free, cow's milk-free diet for no reason, and then is weaned, and then that can make them deficient in nutrients. It can delay their bone age. So I think it's really important to re-challenge so we're not misdiagnosing this. And the amount we're diagnosing cow's milk protein allergy is going up, but the incidence is not necessarily going up. So we want to try and not overdiagnose this by asking parents to re-challenge. A lot don't actually do it because if their baby's better, they don't want to go back and make them worse, but it's really important to stress it if you can. Pyloric stenosis was the other thing that crossed my mind. So let me just, hopefully you can see all the pictures. So this is something which, if your medical school was anything like mine, this was really drilled into us quite a lot as a medical student in my paediatrics block. They all said, look out for pyloric stenosis. I've seen it twice for the children that I've been looking after. But it's really interesting actually when you see a child with it. It's very textbook. It happens at about 2 to 3.5 per 1,000 live births, and it's often when they're quite little, so 2 to 12 weeks old. Think about it then. And it's more common in males, so I think the ratio is about 2 to 1, so it's twice as common in boys and girls, and it's more common in a firstborn child. Don't ask me why, but it is. I know. I don't know why. So clinically, you can get a lot from the history, and 14% of cases have the classic triad. I'll go on to that in the next slide of symptoms. But about 87% of cases will have at least one classic sign. You can get a lot from the history in the sense of the projectile vomiting. So obviously, I don't know if you know how much pediatric knowledge you guys have got, as I said, but pyloric stenosis is the hypertrophy of the pylorus muscle in the stomach. So if you can see in this diagram here, the reason that you get the projectile vomiting is because the food literally can't get past the hypertrophy of the pylorus, and so it stenoses the gastric outlet, and it's projectile because you get forceful expulsion of the vomit after that. And they typically say that projectile vomiting is you're standing a meter away and it will hit you. So I've heard parents say projectile and it literally means it's just landed here, and I wouldn't call that projectile. In terms of what you can do to diagnose it other than the history is you can do blood gas analysis, which we'll go on to, and also ultrasounds is a really good imaging tool for diagnosing pyloric stenosis. So does anybody know what symptoms are in the classic triad for the symptoms of pyloric stenosis?
Okay, I'll just give people a few seconds. Don't want to jump the gun.
Do you know them? Have you got them in your head, James?
That's a good point, actually. I don't think I definitely don't have all three. So hopefully someone will be able to help me out. Okay, still waiting. So I think the projectile vomiting would be one.
Yeah.
Do you get an olive-shaped mass in the abdomen?
Yeah, perfect.
And now I'm really annoyed at myself for not knowing the third one.
This is the hardest, I think, of the three. So. Oh,
wait, we've got one. Visible peristalsis.
Yeah, exactly.
Fantastic. So, well done, Olivia.
Well done, Olivia. So projectile vomiting, the olive sign. So the olive sign is literally the pylorus you can see in babies. I've never seen it actually. In the two pyloric stenosis cases I saw, they didn't have the olive sign. And visible peristalsis, they didn't have that either. So in the statistic that said 80% have one of the classic triad, I definitely think that is the projectile vomiting out of all of them. But this is why in the examination I said it's definitely worth just looking at the tummy. You may also hear paediatricians say, we'll do a test feed. And we had babies who came in with projectile vomiting, and this case that we watched mum feed to see if we could see any of the visible peristalsis. So it's worth doing if you've got the time and get the chance. So this blood gas, so a lot of you probably will be able to spiel off what the blood gas is in pyloric stenosis. So you would normally get a hypochloremic, hypokalemic metabolic alkalosis. So there are lots of different biochemical ways that the body creates this picture, but effectively you're vomiting your hydrochloric acid, you lose your chloride ions. The body then, this is very complex physiology that I'm trying to understand myself, but the body then loses bicarbonate, so it's unable to compensate for the alkalosis. So then you get the hypochloremic metabolic alkalosis, and that's the first thing that you'll get. You also get you also get a low blood volume. So then you get excess aldosterone, which basically expels potassium. So then you lose your potassium, and you also get the body favouring absorbing hydrogen ions in favour of potassium ions. So then you lose potassium ions through that as well, because the body's trying to compensate for your alkalosis. So because your potassium hypokalemia is actually a later on effect, because it's all the body adjusting to everything. You may not see low potassium straight away, but you're more likely to see hypochloremia, so low chloride. So it's a hypochloremic metabolic alkalosis. The management of pyloric stenosis, first and foremost, particularly if you're in a district general hospital, is to tell the surgeons at the tertiary centre and correct the child's electrolyte abnormalities. They may be quite dehydrated because they're been unable to keep anything down. So just make sure you're giving them IV fluids and according to what they need. So putting in potassium if they need potassium. And an NG tube may be helpful, but to be honest, if they've got the stenosis, then it may not be helpful, because even if you put an NG tube in, you won't be able to still get anything through the hypertrophied pylorus. Once you then refer to a tertiary centre, they'll do a pyloromyotomy, but they won't take them unless their electrolytes are normal. So they'll ask you for a most recent gas. They basically just widen the stenosis gap, and then children will come back with a scar, but will be much better. So,
just a quick question about the management there. As I don't know whether as an F1 or an F2 was your PEDS job, would you be likely to be cannulating a baby or inserting an NG tube? Is that something that you got to do and would feel confident in doing?
So I would definitely say that. So this was an F2. I was very keen to get stuck in with skills. So I did do bloods and cannulas. It's not something that you're expected to do, but I think you're very much encouraged to try. NG tubes, I've never put an NG tube down a child. It's more the nurses who do that. And I would say that it can be quite tricky. So if you're doing it for the first time, I definitely go and watch a nurse, because they're the ones who do it. But ironically, sometimes if they can't do it, then they'll come to you. And I would say to them, but I've never done it before. I don't know why you're coming to me. But it's great experience to watch any of these skills being done. And I think cannulating, particularly babies, is really great experience, because toddlers are hard because they're wriggly and strong, but babies, you can see their veins really nicely in their hands. And
how interesting.
It's actually easier than one might think.
Okay, cool. Thank you. That's very interesting.
Yeah.
Yeah, the chemotherapy nurses are the same on my haematology ward. They are far better at lines and stuff than I am. But if two of them can't do it, they ask me to do it as if I have any chance.
Exactly. It's strange, isn't it? Perfect. So just going back to the case, I'm not sure if you'll be able to remember the case from before, but we discharged that baby home because we said to mum that we felt like it was more reflux. The baby had only had Gaviscon for 1 day. We said give it a bit of time and it should settle down. Then represented only 2 days later, but had lost weight, and we'd weighed baby on the same scales. Had an abnormal gas, which was the gas that I showed you, and fewer wet nappies. Then we thought, okay, we think this baby is a pyloric stenosis. We did an ultrasound. This isn't the ultrasound, but we did a ultrasound, which showed hypertrophic pyloric stenosis. So we were then referred to a tertiary centre to the surgeons for pyloromyotomy. So the reason why I told you guys about that case is because I think it's really important to start simple. I think it would be unreasonable to assume that that child with projectile vomiting, which I know that I put in that inverted commas, but it wasn't projectile when they first came in with a normal gas. He'd only tried Gaviscon for a day. I think it was very reasonable to actually not jump to pyloric stenosis. But when they represent with an abnormal gas, weight loss within 2 days and fewer wet nappies, that was the time to think about other things. And also just think about safety netting. So think about what things are red flags in our brains, and think about that you want to tell the same advice to parents. Just in the sense of the fact that that baby had wet nappies, this is just a bit of a idea of signs of dehydration in children. So just things to look out for. It's similar to adults in the sense of dry mucous membrane, sunken eyes, if they've got cool peripheries, check their CAP refill. They may just be a bit listless. Lack of tears when crying might make you think that they're dehydrated, reduced number of wet nappies. This is from NICE guidelines as well about differentiating between clinical dehydration and clinical shock. So may make you think about whether you're giving NG fluids or whether you're giving IV fluids and boluses, or whether you're happy just to do an oral fluid challenge. That's also an option for dehydrated children. So I've just had another case here to think about. So, sorry, this. So think about this. It's not as long as the other one, but it's just worth thinking about. So a 6-month-old baby presents with abdominal pain for the past 4 weeks. It happens on and off. So parents are telling you, you know, it's not all the time, it's just every now and again. They've had some diarrhea recently, but it's turned quite red and sticky recently. And baby's also been vomiting, and that's just recently changed colour. So this is not an actual case that I've seen, but I think it just displayed some red flags quite nicely. So on examination, you feel an abdominal mass on the right side of baby's tummy. They also have abdominal distension and guarding, so they're really reluctant for you to touch their tummy. So hopefully running through your brain is thinking that they're peritonitic. I would be a bit worried if I felt a tummy that was guarding and distended, and the fact that the stool is red and sticky and the vomit has changed colour. They're my red flags for a 6-month-old. And in terms of the vomit changing colour, Mum shows you a picture and it looks like this. Not that volume from a 6-month-old baby, but it's this colour. So hopefully you will all think of this as bile-stained vomit, looking lovely and green. And I just wanted to show you an example of intussusception. So the intussusception is a problem in babies whereby they're often it's the proximal part of the bowel invaginates into the distal part of the bowel, and you get this sort of telescoping effect. And it's most common in the ileocecal region. So you often get the ileus going into the cecum, and the reason you get it that way around is just because of bowel peristalsis. So you just think of the wave going and it just goes through. So this is this bit here. Can you see my mouse? Yeah. This bit here is the ileocecal junction, and 77% of cases are there. So this is where, in the sense of this case, when he had right side of the tummy, that's where your ileocecal region is. So the things that should have hopefully made you think about intussusception in this child would have been the red sticky diarrhea. So this child is having colicky pain, which is what I meant by it being on and off. And the fact that the loose stool has turned quite red and sticky is telling me that there has been some ischemia happening to the bowel, which is causing the mucosa of the bowel to slough off. So through the invagination, there must be some blockage of the blood supply, and mucosa sloughing off and causing the red currant jelly stool, as you'll typically hear it for intussusception. Also, it seems like this child is obstructed. So as you can see from this picture, you've got complete obstruction of the bowel here, and it is likely that just more, and the constricted blood supply, so it's likely that more and more bowel has come into this, and then that's what's completely occluded it. They're having the bile stain vomit and they're peritonitic. So what would you do? Any suggestions about what you might do in this baby? I've put a clue on the picture, on the slide.
Again, I'll give people a little bit of time to think about it.
Yeah, that's absolutely fine.
Am I thinking the first line investigation would be an ultrasound though for interception?
Yeah.
Is that?
Yeah, definitely. So the reason why I put an X-ray on there is because if I had a child who was peritonitic, I might think about an X-ray just for perforation.
Yep.
But definitely an ultrasound for intussusception is great. And do you know what sign you might see on ultrasound?
I think it's a whirlpool sign.
Yeah, so there's lots of different names for it, I think. So you can call it a whirlpool sign, there's target sign, donut sign, lots of people have different things. It's basically when you can see, you sort of get a cross-sectional view almost of the intussusception, and you can sort of see it as a circle with then the darker circle in the middle, and that's your two bits of bowel.
Okay, yeah, no one's jumped in with any suggestions yet.
That's fine.
I'm not trying to think what I would do. I mean, I would probably ask for help from someone more senior myself for a start.
Yeah, absolutely. I would definitely be asking for senior help with this patient as well. They are sick, definitely. Other imaging options, as I've shown here, is an abdominal X-ray, as James and I was just discussing. So if you're worried about bowel perforation and you've got a peritonitic child, I think an abdominal X-ray is reasonable. What you can see here is the dilated bowel, and you can see the bowel invaginated into the other bowel, with the arrows are showing it really nicely. So Radiopaedia is actually a really good resource for any imaging, so have a look on there if you guys want to see. I would definitely give this child IV fluids and an NG tube. So in a similar way to adults, if any of you have done general surgery, you will know about drip and suck. You want to decompress that abdomen if you think they're obstructed with the NG tube, and you want to give them fluids to rehydrate them. Abdominal X-rays we've mentioned, or an ultrasound, possibly ultrasound if they're as a second line if they were this unwell, and an urgent surgical review. I just mentioned intussusception as thinking about abdominal obstruction in the sense of vomiting in children. Or there's other options that you can have malrotation for any other reason. Children with Down syndrome are more at risk of malrotation, volvulus. So just think of it in that same way that you would have this obstruction picture. And it's what we would do is similar to this for any of them. And then the surgeons will be able to, or the tertiary centres will take it from there. But it's just figuring out your sick children who are vomiting and changes. So the main things that I wanted you to take home from this presentation was thinking about your history. Is this true vomiting? You want to know, is this positing? Or are we actually dealing with a projectile vomiting pyloric stenosis or a bilious vomiting obstruction? With regards to reflux, I really want to encourage you to think about conservative feeding advice, think about smaller volumes more frequently, think about keeping baby upright every 30 minutes, and really encourage mums to keep breastfeeding if they are breastfeeding, because it can be demoralizing. In terms of cow's milk protein allergy, avoid overdiagnosis because it can have consequences. So think about other things first, really get to grips with your history in terms of what are the precipitating factors, have they excluded everything, have they reintroduced it, and stop mums and babies excluding things from their diet, which can then have nutritional impacts for no reason. For pyloric stenosis, ultrasound's a really good diagnostic tool. So in A&Es, sorry, they are thinking more about using point of care ultrasounds to diagnose. With ultrasounds, you can do so much in children. You can do cranial ultrasounds, you can do abdominal ultrasounds, but it's a really good diagnostic tool and often quite quick to get. Every radiologist will do it as well. It's not like you've got to convince them it's no radiation. So I would say that don't rely on gases. Ultrasounds are really good. Think about your red flags as a final take-home message. Serious causes can be GI or non-GI. And I've not mentioned it in this presentation. It would just be impossible to go through everything, but really think about your intracranial causes, your meningitises, your hydrocephalises. Think about any change in vision, any developmental delay. Think about measuring your head circumference. Think about fevers, irritability, and don't just think gut, think brain as well. And I would love to take any questions if anybody has got any. Otherwise, this is the QR code for the feedback, and I'd be really grateful if you could fill that in. But I hope you all enjoyed it, and feel free to ask any questions. James will pass them on to me through the chat.
Okay, thank you very much. I know I certainly learned quite a few things during that talk, so that was really useful.
Good.
Yeah, absolutely, guys. Do fill out the feedback form as well as the QR code here. There is a link in the chat to the feedback form. Similarly, on Facebook in the event, there is a link there. But do go back and do this. The lecture will be available on YouTube, on Medal as a recording. But yeah, let us know what you think. It's useful for us for our own portfolios, but equally it allows us to improve the webinars week on week and produce more great free content for all of you. So from the chat, the only thing I've got so far is a thank you, great lecture, which is always nice to hear. Glad to be appreciated. Other things, just to give people a minute or so to come with any questions that they do have.
That's absolutely fine.
Yeah, next week I will be doing a lecture on paediatric prescribing. I will spam you all via Twitter, Facebook, however I can get in contact with you to publicize the event. And also, if anyone is interested in writing articles on paediatrics, we've just uploaded a whole load of topics to the Mind the Bleep website. So do go on there, check it out. And if you're interested in writing, get in contact. Okay, so we've got many thanks, instructive and interesting. Thank you so much. Sorry, could you explain the high bicarbonate on the pyloric stenosis, please? Thank you.
So, sorry, let me just work it out. So let me think. Sorry, the renal physiology is not my strong point. So you lose chloride ions because you are losing hydrochloric acid because you're vomiting, and that gives you an alkalosis because chloride makes you acidotic, and then you, from my knowledge, you then lose bicarbonate, but then that would make you more acidotic. Let me see if I can find out. Because I understood it before and now I'm thinking about it too much and I don't understand it. Bear with me.
No, that's absolutely fine. We can always, I can always post the like a worked answer.
Yeah.
Nisha in the either the Facebook group or on Medal.
Yeah.
Because it's always best to get back with if we're not 100% sure, because the complicated physiology is certainly not my strong point either.
No, it's really confusing because there's lots of different the electrolyte things that go on with pyloric stenosis, so it can get really confusing. So it's the fact that basically the low chloride levels reduce the kidney's reduce the kidney's ability to excrete bicarbonate. So I think it's a dual transporter, like a bicarbonate chloride transporter. So if you've got low blood chloride, then your kidneys are unable to excrete the bicarbonate because the dual transporter won't work.
Okay, yep, that makes sense.
Yeah.
Okay, hopefully, Maria, that answered your question. I can't see any other questions coming in. But no, thank you very much, Nisha, and thank you everyone for joining us on a Tuesday evening.
Yes, thank you.
Yeah, and hopefully see you all next week.